The defense calls Dr. Priya Bannery.
If you'll raise your right hand, please, Doctor. Do you swear or affirm to tell the truth, the whole truth, and nothing but the truth, so help you God?
I do.
You may have a seat right there.
Thank you.
Okay, Mr. Selden.
Thank you. Good afternoon, Dr. Bannery.
Good afternoon. Can everybody hear me? Thank you.
Yes. Tell us your name and how you spell it.
My name is Dr. Priya, Priya, and last name is Banerjee, Banerjee.
Where do you currently work and what's your title?
Sure. So, excuse me, I am self-employed at my company named Anchor Forensic Pathology, and I'm based in Barrington, Rhode Island, just outside of Providence.
Have you authored any publications or anything related to it?
Yes, I don't think I fully answered your last question. So I'm a forensic pathologist, and so I've worked in that field going on over 14 years. And so during my training, well, I mean, I'm talking about I was an attending, and then there was training prior to that. So all in all, there were many occasions that I've done research myself and then published those articles, or then became a senior author, helped other individuals perform the projects, and we together presented them and published them.
And that's in your chosen field of forensic pathology, is that correct?
So I have publications throughout. I have cancer research articles. I have some basic pathology articles, as well as many publications in forensic pathology as well.
Okay. Do you have any teaching experience?
Yes, quite a bit. So in Rhode Island, let's see, I used to teach at the Roger Williams University, where I designed and taught a year-long forensic pathology and crime scene investigation course that was 2 semesters. I did that for quite a while, and then I subsequently left that job due to personal reasons. I also taught at the Boston University Medical School, their graduate program in forensic sciences. Again, it was crime scene investigation and forensic pathology, and currently still hold, since I think 2011 or 2012, a clinical assistant professorship at the Brown University Laboratory Medicine and Pathology program.
As a forensic pathologist, do you conduct autopsies and issue reports from that?
Yes, that's one of the many roles I do as a forensic pathologist. That's really what I'm trained to do. And as you've heard previously, that's one of the main tools we use as a forensic pathologist to make diagnoses.
What? Can you approximate at all how many autopsies you've done in the past?
That's a gross approximation, and I would say probably close to 3,000 now. So autopsy, my training stems back to my days at residency at the Johns Hopkins Hospital, where we learned and performed autopsies. I then went on to do a fellowship in forensic pathology, where I was, day in and day out performing autopsies. And then I was an assistant medical examiner for the state of Rhode Island for over 11 years. So again, very diligently doing autopsies. So all of those together, plus I've done some service work in various other offices that needed help, such as New Hampshire, Maine, Las Vegas. I've done that. And so this is just, I don't keep tallies, but I would say approximately, let's say 2,900 to 3,000.
Fair enough. Are you board certified in any of these areas that you're talking about?
Yes, so I after I completed my residency at the Johns Hopkins Hospital, I sat for my pathology boards, which was in the field of anatomic pathology. So that's like being in a hospital, looking at slides, whatnot. Autopsy is a part of that. So I was generally boarded in anatomic pathology. And then after I did my fellowship training, I was then eligible and on the first attempt passed my forensic pathology boards.
Do you have any medical licenses anywhere?
I currently hold 2 active licenses, one in the state of Rhode Island and one in Nevada. I also have a inactive, good standing licensure in Pennsylvania.
At this time, I would like Dr. Bannery certified as an expert in the field of forensic pathology.
Does the state wish to engage in voir dire?
Your Honor, the state accepts the witness's credentials.
All right, the court declares Dr. Banerjee to be an expert in the field of forensic pathology and anatomic pathology.
Thank you.
Permission to approach the clerk, Your Honor?
Yes.
And Your Honor, I am asking that this particular exhibit be marked as defense exhibit, whatever the next number is.
It's defense exhibit number 12.
Thank you.
Permission to approach the witness, Your Honor?
Yes, you may.
Dr. Banerjee, I am handing you what's been marked as defense exhibit number 12. I'm going to ask you to refer to this document. I'm going to go back and ask you some questions, okay?
Sounds good. Thank you.
Could you identify this document, what it is?
So this is my 7-page report that I submitted to you that summarizes or contains all my conclusions related to this case.
Okay. You're starting to fade away a little bit.
Oh,
Please
sorry.
talk in the microphone. Thank you.
I'm very rarely accused of that.
On page 2 of that report, you specify what records you've received in preparation of that report. Would you please go through the records you've received?
Yes, so I've itemized in my report in no particular order. All of them were submitted digitally. So just the first autopsy report for Michael Brandon Cochran, West Virginia, number 2019-3671. That is the first autopsy that Dr. Kubitschek performed. I also have medical records, 2 sets, one from Raleigh General and the other from Charleston Medical Center. I have an array of scene photographs of the candidate scene, including multiple pictures of a Humalog insulin Lispro vial. I have Dr. Uribe's second autopsy report and Dr. Diane Krieger's expert report.
Now, you listened in to expert reports or expert testimony in this case, but that was subsequent to you authoring this report. Is that correct?
Correct. Yes, I was allowed to by the judge with permission to also listen to Drs. Uribe and Krieger testify, but my opinion as written here is all formulated based on their written reports as well, and the summation of all this.
Okay. I'd like to skip down to the bottom of page 2.
Okay.
You have a heading marked discussion. Do you see that?
Yes.
Okay. I'd like to skip over paragraph 1 for now and go to paragraph 2. In that paragraph, you state that Mr. Cochran first underwent an autopsy by Dr. Kubitschek on September the 4th, 2019, which was 7 months after his death. Is that correct?
Yes, approximately 7 months.
Okay. Your Honor, I have another exhibit that I'm going to be questioning this witness about. Permission to approach the clerk.
Very well.
Defendant's exhibit number 13, Your Honor.
Thank you.
Now, I'd like to warn the jury ahead of time, these are photographs and they're somewhat gruesome. Dr. Bannery, can you identify this exhibit?
Yes, so this is a hard copy printout of an array with 4 autopsy pictures with the same case number that I referenced, 19-3671, with Dr. Kubitschek's initials also on the placard in the photos. So these are at least 4 of the many autopsy photos that were submitted to me.
At this time, I'd like to move for admission of Dr. Bannerjy's report and this exhibit.
Any objections, Mr. Truman?
No objection, Your Honor. Thank you.
All right. Defense exhibits 12 and 13 will be admitted into evidence.
Now, you've already identified this photograph. I want to go back to your description under decomposition, page 3, paragraph 2.
Okay, let me just flip there. Yes.
Does this photograph accurately convey the advanced state of decomposition as photographed by Dr. Kubitschek in his autopsy?
Yeah, so this, unfortunately, embalming and burial does not keep the body in the same state as when one passes away. So even though the procedure is supposed to, it's still not perfect. And so you can see that 7 months later, Mr. Cochran's body was in a moderately decomposed state with moderate insect activity present, and those are words extracted from Dr. Kubitschek's autopsy. That's how he described it.
I'm going to remove the photograph.
All right.
On that same page, what was the description and the condition of Michael Cochran's heart on autopsy?
Yes, so the heart weighed 450 grams, and it wasn't described clearly as such, but assuming it was also moderately decomposed like the rest of him, it was, it follows that weight, as you've heard earlier, tissues and organs, as they fall apart with decomposition, they get lighter in weight. And so taking that into account, this is a relatively enlarged heart for someone his size and his stature.
Why is that significant, the enlarged heart?
So the heart is ironically one of those muscles that you don't really want to enlarge unless you're an Olympic athlete or very well conditioned. It often enlarges secondary to what we say stress. Now, stress can be anything like high blood pressure, anything that's sort of a continued stress on the body. It's not one episode. It's going to be longer term effects. So sometimes chronic substance abuse, exercise can help. But when we say it's a pathologically enlarged, abnormally enlarged, that's not a healthy heart.
You have a discussion about pseudoephedrine use.
Yes.
Please explain that.
Sure. So within the clinical records I was given, such certain substances that are considered controlled substances, which pseudoephedrine is one, is monitored, and the prescription sort of history is monitored. So that's how I knew he was on it. And pseudoephedrine is Sudafed, and we know that one of its side effects it's a stimulant, meaning that it will raise your blood pressure.
What about your statement about reported history of pseudoephedrine and stimulant use and the use of enclophamine use? How could these factors have affected Mr. Cochran?
Sure. So I assume that enclomiphene, wasn't a prescribed medicine. It was what the records say was illicitly obtained over the internet, and non-prescribed, I should say. And so all of these factors, when your heart is enlarged, it is a risk for sudden death, which is what we call an arrhythmia. The heart has an electrical system that helps us beat. Even as we sit here, we don't have to think about it. And when the heart gets thickened, abnormally so, the electrical system can basically short circuit, and then you miss a beat, you don't have a heart rate, you don't have a blood pressure, and you die. There really isn't any fingerprint of an arrhythmia. That's an electrical signal, right? So when you're alive, there are cardiologists that specialize in that, and they can, like an EKG is the electrical tracing of the heart. But once you are deceased, there's no way to really, there's no traceable rhythm. And so structurally, when we see an enlarged heart, we're worried about an arrhythmia as a possible cause of sudden death.
Could these factors in your discussion about a fatal arrhythmia or heart attack, could this have been a possible factor in Michael Cochran's death?
Yes, I just say arrhythmia, heart attack, I sort of classify differently, which I won't get into, but the abnormal rhythm would be an arrhythmia, and if it's a fatal, there's different tracings, which I'm not going to get into, but fatal arrhythmia can occur, and obviously with a decomposed heart, just like the rest of his body, that really limits making the diagnosis under the microscope. We can, again, just say that the heart was enlarged based on its weight.
So from that explanation, a fatal arrhythmia would not show up in autopsy, correct?
Correct. We have a structurally abnormal heart, which we know is at risk, but a fatal arrhythmia leaves no identifiable sign at autopsy, especially in a decomposed specimen.
What findings were made regarding the possibility of pancreatic tumors in Michael Cochran's body?
I know there's been some discussion about this, but upon review of the first autopsy report, again, the pancreas is one of the first organs to decompose in the body. It's full of enzymes, and as soon as we die, they start leaking, and that's what causes the pancreas to basically disintegrate. And so I think it's difficult, and I think it's improper to say that a pancreatic tumor was excluded, because 7 months later, the pancreas isn't going to be very recognizable. Even if it is, it's not going to be intact anymore to really see any types of tumors. These tumors, such as an insulinoma, can be less than 1 centimeter big. It can be millimeters, but it can still have a functional effect, which I find fascinating. But again, that's not going to be identifiable on a decomposed pancreas or organ.
Okay, and I may have missed it in your explanation. I just want to clarify. Can pancreatic tumors cause hypoglycemia?
Oh, yes, sorry if I wasn't clear on that. Yes, so that's in one of the potential causes of hypoglycemia is a pancreatic tumor if it creates insulin. So tumors don't act like normal organs. And so if it's a tumor of the cells that make insulin in the body, and there's an sort of bad acting collection of them, then they form this tumor, and then they can pump out insulin that could cause low blood sugar hypoglycemia. There was no such, I think the capabilities of identifying such is very limited in a decomposed body.
Dr. Uribe stated that pancreatic tumors on autopsy were excluded in the first autopsy. Is that a correct statement?
I think not identified versus excluded are two different issues here. Not identified is true because the pancreas and other organs, again, are decomposed. Excluded is inaccurate because, again, that decomposition means it's 7 months later and it could have been there. We just can't see it based on the condition of the organ and the body in general.
I'd like to call your attention to the paragraph that's numbered number 3 on that page. Okay?
Yes.
You discuss post-mortem, meaning after death, toxicology tests performed. What's toxicology?
So toxicology is the basic testing of blood and other body fluids or tissues to see to try to detect, identify, and quantify any medications or substances that's in someone's body at the time of death.
Would you please discuss what tests were done or weren't done in connection with Michael Cochran's body? And along those lines,
So again, this is 7 months later.
I have a specific question.
Oh, I'm sorry. I thought
That's
you
all right.
wanted me to answer.
There's a discussion that there was no testing prior to Michael's death of, first of all, insulin. What's the significance of that?
So when he was alive then, you're
Yes.
saying? Okay, because we talked about postmortem testing too.
No,
So
I'm talking about prior to Michael Cochran's death.
Sure. So my review of the hospital record showed that there was, although low blood sugars were noted, there was no associated laboratory testing related to insulin, C-peptide, proinsulin levels, or any other medications like oral anti-glycemic agents, which are what you take to lower blood sugars, done in the hospital.
So those various tests that you're talking about, tests for insulin, tests for C-peptides, anabolic steroids, those all could have been done prior to Michael Cochran's death, correct?
Yes.
But they weren't done, right?
Per the medical records, they were not done.
and according to hospital records, etc., one of the reasons those tests weren't done was because when Michael Cochran was admitted to the hospital or hospitals, there was no suspicion of insulin being introduced into his body. And I'm talking about what they call exogenous insulin, insulin that's not produced by the body. Would that be a correct statement?
Yes, I saw no notation or differential diagnosis listed that, oh, sorry. I did not see any notation or differential diagnosis listed within the medical records for that diagnosis, like exogenous insulin having a role in his hypoglycemia.
Okay. Is there any explanation for Mr. Cochran's urine screen, which was positive for benzodiazepines?
So this was a perplexing result to me. I think there was some confusion. Dr. Uribe said that, and there was, midazolam detected in the postmortem toxicology. Midazolam is a benzodiazepine that can be used as a sedative or anesthetic, but that was given later in the hospital, and the urine screening was done very close to his admission to the hospital. It was done at 21:05, which is 9:05 p.m. The day of February 6th. And so he had not been given, there's no records within the nursing records or the doctor's orders that he was given any such medication in this class yet. So that means in the urine drug screen, there's an unexplained benzodiazepine positivity. Now, that just means I don't know what it is. I don't know where it came from, but it's a suggestion that he's on this something, at least one, if not more, benzodiazepine medications. And that's from the urine testing.
Okay. Let's go down to paragraph 4 on that same page.
Yes.
In that paragraph, you discuss the second autopsy, which was done by Dr. Uribe 4 years after Michael Cochran's death.
Yes.
What's the significance of an autopsy being done 4 years after death?
Well, I think in this, speaking specifically with this case, unfortunately, again, the embalming is not perfect, as we saw 7 months. So although there's no photographs, there was a description written by Dr. Uribe that the body was nearly skeletonized. There was some residual tissue, but mainly bones. And so obviously that decomposition has continued. Mr. Cochran's body was, buried again and then had to be re-exhumed. So again, his body's undergoing decomposition to almost no tissues remaining. And the ones that he had described that were there with the body were all very disintegrated in a medical bag, in a plastic bag. So you can't really make any further conclusions from them. They're not intact anymore to make anything meaningful.
Because of the advanced state of decomposition, which has continued, does it make it harder to reach a conclusion in an autopsy?
So we have 2 autopsies here with 2 varying stages of decomposition, one obviously far more advanced than the other. But anytime we have decomposition, you really are working with not as perfect a body as it had been when he first died. So obviously, when I get asked the question, when do I need to autopsy my loved one? Usually I say within a week to really get meaningful results. And as time goes on, even with embalming, as you've seen, there's decomposition because the way our bodies, our tissues react, they're just going to start disintegrating. They're no longer they're not healthy living tissues anymore because the person's not living. And so you're automatically handicapped to make some diagnoses. It's still very worthwhile doing a decomposition or decomposed autopsy. You want to make sure there's no trauma, there's no big, you can see some diagnoses, even natural diagnoses, you can see trauma, even some toxicology can be done, but it's still a hindrance at, due to the decomposition being there. And actually, in decomposition autopsies, there's an extensive explanation that I, sort of qualify the description of the organs, as well as the toxicology lab has to be, notified that, hey, this is not an ideal specimen, this is a decomposed specimen, and sometimes you even can't send as good a specimen to do the testing because it's not available anymore.
Now, if you can answer this question, fine. If you can't, that's fine too. In general, if an autopsy is done 7 months after death, and an autopsy is done 4 years after death, would the results in the first autopsy be more easily quantified or valid, let's say, than the second autopsy?
I think that's a very broad question.
Okay.
I can speak that, again, it's still worth examining a body at any time. I really look at it when, even with decomposition present, you want to make sure there's no identifiable trauma. So even some, in skeletonized remains, I've done many of those, you look at the bones to make sure there's no fractures, tool marks, gunshot wounds, anything like that. Do the bones tell you about the patient? Sometimes you can have surgery remnants, right? You can have hardware, you can have skull fractures, whatever it may be. We x-ray them, we look at them. That can be very meaningful. You can do DNA on bone, etc. But as the organs and soft tissues decompose, more information is leaving, right? So as time goes on, less and less information is available to make, I guess, like toxicologic analyses, even looking under the microscope, even at 7 months. You can see with moderate decomposition, it's not a worthwhile exercise.
I believe that Dr. Kubicek took some tissue samples, or was it Dr. Uribe, for toxicology analysis? Do you remember?
Yes, so Dr. Kubicek did. Yes. So there was at least clotted blood and maybe some tissue samples that he sent. I don't have the report in front of me, but I know that was the analysis that resulted in the midazolam, that one therapeutic, meaning medically given, prescribed medicine in his blood detected.
But generally speaking, those slides were pretty much useless, and I believe Dr. Uribe said he couldn't make any definitive findings as to those slides. Is that correct?
Sorry, just to clarify, I was speaking about the toxicology.
Okay. I'm talking about the slides.
I see. Maybe I misspoke or misunderstood. Excuse me. When you talk about slides are where we look under the microscope. So the way it works is you have to have a light and you have to have the glass slide that has a very thin, even thinner than paper, layer of tissue on there. So that tissue means it's a section cut from the organ you want to look at. So heart, lungs, liver, kidneys, whatever it may be. And it's specially prepared in a lab, and it has at baseline usually pinks and purples to help me with my trained eye, or my colleagues like Dr. Kubicek or Dr. Uribe look under the microscope and make an interpretation. But that also, again, depends on the integrity of the tissues. So as the tissues fall apart, the detail under the microscope is no longer available. So I don't recall exactly what Dr. Kubicek's conclusions were if he took slides, but I know Dr. Uribe basically didn't submit them because no meaningful diagnosis could be made. The tissue was in such unrecognizable, decomposed state that it's not worth anybody's time, effort,
So
or money
for
to do it.
analytic purposes, those tissue slides were pretty much useless. Is that correct?
I'm not even sure he made slides. I thought he just retained them in little plastic containers in case he needed to, but I don't think he even made the slides. His comment was that it was something like no meaningful diagnoses could be made from them.
Pretty much useless, right?
Yes.
At paragraph 5 of your report, you discuss the documenting of Mr. Cochran's pseudoephedrine prescription, and then you discuss benzodiazepines, which were positive in his urine. How are these two substances related, and what's the significance of them?
Okay, so there are two medications that are controlled, meaning they have medical uses, but they're also regulated because they can be abused. So that's why each state usually has a prescription drug monitoring program. And as a part of the investigation and medical records, I received the printout for Mr. Cochran. That printout has a log that he was on pseudoephedrine for many months. However, benzodiazepine is a controlled substance, meaning like it's a medication, has plenty of medical uses, but also has potential for abuse. And there was no tracked benzodiazepine on anywhere, actually. I didn't have it in his list of medical medications at home, and I did not have it on the state prescription drug monitoring program. So I'm sorry, just to conclude
From your discussion and report, could Mr. Cochran, prior to death, have overdosed on benzodiazepines?
So, yes, that's where I was leading, that, a urine toxicology, when someone shows up at a hospital with altered mental state, meaning they're not talkative, they're confused, or they're not responding, that's why it aids doctors and clinicians that maybe we can find out what's in him because he can't tell us, and maybe that'll help us undo the effects of it, and if it'll allow him to wake up. Does that make sense? And so that is one. Overdose is a possibility. I have no idea which benzodiazepine this is. I don't know how much it is. It could be one, it could be more than one. I have no idea. I just know that that was a very strange result, given that he's not prescribed this at home. And then again, it's a drug of abuse, meaning if you're not prescribed it and you're using it, that is misuse of a prescribed medicine, or unprescribed medicine for that matter. I know you can get it off the internet. I've had other cases related to benzodiazepine overdose that could be illicit, if you will. So I think that's a strong differential,
Okay.
given.
Let me interrupt you right
Okay.
here and clarify. Did you state in your report that benzodiazepine overdose is a common cause of death alone or in combination with other substances?
Yes, at least where I've practiced, benzodiazepines are often misused, abused, if you will, and if taken in excess can cause overdose, as I said, alone, or it's often used with many other substances that may or may not show up on a urine drug screen.
Okay. Did Mr. Cochran, prior to death and according to the medical records, exhibit any symptoms of benzodiazepine overdose?
I mean, any overdose, the way it affects your body, and a benzodiazepine.
I'm asking specifically, Mr. Cochran, in your review of the medical records,
Yes.
did he exhibit symptoms of benzodiazepine overdose, and what symptoms are indicative or indicate possibly
Sure.
benzodiazepine overdose.
Sure, so they're non-specific, but respiratory arrest where he stops breathing. He can aspirate gastric contents into his lungs, like meaning vomit will come up and he'll breathe it in. Confusion, collapse, all of that is possible as the excess medication use and abuse causing overdose.
Can it cause seizures?
Not usually.
Okay.
I think, just to clarify, I think if he's in a prolonged state due to an overdose where his brain is deficient of oxygen, that could have seizure-like activity because the brain is injured. But the medication in and of itself does not cause seizures. It can sometimes be given for seizures.
Is hypoglycemia related to benzodiazepine overdose?
I think it could be. I don't know that it's directly related, but I think once the body starts getting in dysfunction and disarray, you can see hypoglycemia.
Okay. So it might have been a possible cause of Michael Cochran's hypoglycemia. Is that possible?
Benzodiazepine overdose is in the differential.
Is that a yes?
Yes, sorry.
Let's take our afternoon break right now. Members of the jury will break for 10 or 15 minutes. Please do not discuss the case among yourselves or with anyone else. You may follow the bailiff to your jury room.
That's the one we sent out. And I'll show you where to put and I'll show you where to put those two.
All right, we continue with the direct examination of Dr. Bannery. You may proceed, Mr. Selden.
Thank you, Your Honor. Picking up where we left off, at the top of page 4, the first complete paragraph, you state that although it is not studied well, hypoglycemia is a real and life-threatening condition that may occur in benzodiazepine poisoning. And you go on to say, thus, this is a real possibility for Michael Cochran's cause of death. If I am interpreting that correctly, what you're saying is benzodiazepine may cause hypoglycemia. Then the hypoglycemia may result in death. It's kind of a progression. Is that a correct interpretation?
Correct. I say that this unknown benzodiazepine at unknown levels, there's reports of benzodiazepines causing low blood sugar and could be critically low, as in his case, to then cause death. I don't know that to be a fact, but it's in the differential.
So benzodiazepine poisoning may cause hypoglycemia. Is that correct?
Yes, there was an article that I cited related to that matter.
Okay. I'd like to go to paragraph 6 on page 4. You state that, quote, the focus on hypoglycemia as the sentinel, or most important, abnormality is surprising. What do you mean by that?
I get further into it in the discussion, but basically, when Mr. Cochran presented, not only was he not alert, not responding to commands, etc., when they tried to figure out what was wrong with him, there were multiple laboratory abnormalities. So they drew his blood, analyzed it, and there were a whole bunch of laboratory abnormalities, including the hypoglycemia, but also elevated white blood cell count. And then that had a part of it when they look at what's composing that white blood cell count called neutrophils. Those are like the soldiers that fight infection. Those were high in number.
Let me stop you right there and ask a quick question. Elevated white blood cell count is more or less showing that there's some kind of infection in the body or some kind of toxins, because white blood cells fight infection. Is that correct?
Especially this component of white blood cells that now increase the number. They're like the first responders, the neutrophils. And it wasn't just the neutrophils were high, but there's another enzyme called lactate that they tested that was also high that can be seen in sepsis. So it's sort of like painting the picture that, again, that differential, like what could be wrong with him. You then really worry maybe there's an undetected, untreated infection that's causing him to be in this state.
Okay, so, and if this infection was present, which the white blood cells elevated count would indicate, was there any explanation for what this infection is, how it may have occurred, anything about the infection itself?
No. So the clinicians in the ER did say suspected infection, but they did not say what the suspected source was. They just gave him IV antibiotics. And I don't remember which antibiotic, my apologies. But nonetheless, they are also concerned that he was sick from an infection. So it's better to just give him antibiotics and we'll try to stabilize him and then possibly figure it out. That was never figured out from a source, but they did give him intravenous antibiotics. So it got into his body right away.
Okay, now, some mysterious infection in Michael Cochran's body, could that be a possible cause of Michael Cochran's death, either alone or in combination with other things?
Definitely. So if a infection becomes overwhelming and into the blood and really taking over the body, it can be serious enough to cause death.
You talk about there being no suspicion for insulin overdose or self-administration as the cause of Michael Cochran's seizures and coma. I want to make a point here. You listened to some of the testimony. Did you hear any of the testimony that said Michael Cochran did routinely inject himself with insulin? Did you hear any of that?
I think there was some suggestion, I don't remember who said it.
Okay.
It wasn't in the records that I reviewed and made this report based on.
Okay. So given that testimony, an overdose by self-administration is a possibility, right?
After that testimony was given, it's in the differential diagnosis.
Okay. Moving on down the page, would you discuss the broad list that you go through of potential causes of hypoglycemia other than an insulin injection?
Sure, this is a very long list. So I think I've used the word differential diagnosis a few times, and it's what we're taught in medical school and then into practice. You consider all the possibilities, some may be more likely than others, but you do testing to sort of tease that apart. Does that make sense? I sort of work broad and then narrow down. And so when you think about hypoglycemia in a living individual or even post-mortem, you have to think what's contributing to this. And so this is a very long list. Do you want me to go through it item by item?
No, just
Okay, we'll read the broad diagnoses and then go from there. So medication induced, that should probably be, whether it be prescribed or not. Alcohol falls into there, some antibiotics.
okay. Let me stop you here. Now, you're listing other possible causes of Michael Cochran's hypoglycemia. Is that what you're doing?
I'm listing what's called the differential diagnosis, whether it's applicable to him or I think this is organized medical way of approaching this laboratory abnormality, and it applies to him. Was this a possibility in him? It's how you have to think, and then if you go so myopic and pinpoint, you might miss something important. So it's always broad to narrow.
Okay, so these are possible causes, not necessarily in Mr. Cochran.
This
but
is medical,
possible.
right?
Okay.
All sorts of causes. So
Okay.
medication related, which alcohol or other unexplained medications may be there. Endocrine, so endocrine is like what Dr. Krieger practices. That's working of glands and hormones in the body. There can be various abnormalities. Pancreatic tumors, that's why I was saying that sometimes we really look at the pancreas to try to see if there's a identifiable tumor. Sometimes they're so small that you really need like an MRI or like a radiology to pinpoint them, but they can be so subtle but still cause medical problems. And then there's other sort of broader issues such as liver disease, in certain cases malnutrition, starvation, critical illness, so like sepsis, which is that overwhelming infection in the body. You can have certain surgeries, like your immune system can attack insulin in and of itself, even though you have a working pancreas, genetic disorders, sometimes eating disorders like over-exercising, not eating enough, that can
Okay.
really throw your body.
Let me interrupt you there for just a moment, okay?
Yes.
You say that other causes include liver disease. Were you aware in the medical records that at some point it was revealed that Michael Cochran, prior to death, had some problems with his liver enzymes?
I'm aware that they're elevated. Usually when I talk about liver disease being a cause of hypoglycemia, it's not just any liver disease, it's severe liver disease.
Okay, but that could be an indicator of liver disease causing hypoglycemia, possibly.
Quite possibly, I'm not clear on the extent of his liver disease.
Okay. You list severe malnutrition or starvation. Were you aware that at certain times, Michael Cochran didn't feed himself adequately, trying to cut his weight for bodybuilding?
I'll take that at face value. I don't know his personal history.
Okay. You say critical illness, sepsis. Sepsis is infection, right?
Correct.
You say immune hypoglycemia. What is that?
It's a rare cause. It's anti-insulin antibodies, so anything autoimmune means your body's reacting to itself.
Okay.
And in this case, it would be a very rare circumstance that your body's attacking its own insulin and then getting rid of it so that your body thinks you don't have it.
And again, these are possible causes
Right.
of hypoglycemia.
Right.
Okay. On down, you talk about non-pancreatic tumors. We've talked about pancreatic tumors already, right?
Correct.
And these are other tumors in the body.
Yes, and I'm no expert in this field, but my understanding is so different tumors can do whatever they want. And there's something called paraneoplastic syndrome. So these tumors that are already abnormal, they're doing their own thing, can start making chemicals that in the body that act like insulin or even make insulin potentially, but your body's getting those signals even though it's not from a normal pancreas, if that makes sense.
Okay. Now, just to fill in a little bit of information, insulin promotes blood glucose or blood sugar, right? Most often, especially in diabetics.
Yes, you need insulin.
You list skipping meals. Is that a real possibility in a bodybuilder who's trying to cut weight?
I'm not really clear on that. I mean, skipping meals potentially, I think it could be. It probably depends on how severe it is. And it's not something I'm an expert in quantifying. I think it can be a slippery slope to get into a malnourished state
Okay.
that could affect electrolytes or, glucose levels.
You say increased exercise without sufficient nutrition. If Michael Cochran was exercising furiously and he wasn't feeding himself properly or sufficient, that could be a cause of his hypoglycemia. Would that be a correct inference?
I think it's in the list of possibilities.
Okay. Let's go down to paragraph 7. May I approach the clerk, Your Honor?
Yes.
Your Honor, I've collected what was previously marked Defendant's Exhibit Number 10. I'd like to show that to the witness.
All right.
It's my chart.
Dr. Banerjee, this is an exhibit that was previously introduced. You created this table that's reflected in Defendant's Exhibit Number 10. Is that correct?
Yes.
Okay. And you also have that in your report, page 6. I'm going to put both of them on the viewer if I can, or
Okay.
just your chart on page 6. Okay? This is your unaltered table. This is the one that the jury has seen previously,
I see. Okay.
except for my handwritten notations as to a conversion of military time to regular time and my circling of certain entries. They're pretty much the same thing. Would that
Yes.
be
Yes.
correct? Okay.
I think they're identical. You just highlighted some stuff.
Okay.
Yeah. And again, with time conversion.
All right.
But the data's not altered.
Okay. Thank you for that explanation. I think I'm going to use your chart, which is unaltered. Okay?
Sounds good.
I'm handing this back to the clerk.
Just like him. Thank you.
Now, Dr. Banerjee, at paragraph 7 of your report, which hopefully you're looking at, you discuss Mr. Cochran's hypoglycemia when he reached the hospital and a timeline of his sugar levels at pages 5 and 6 of your report. And we have page 6 shown.
Yes.
Okay. Now, you created this chart, did you not?
I did.
And it was based on information that you got from the medical records, is that correct?
Correct. So the date and time plus the glucose.
I'm going to get into that.
Okay, sorry.
I'm going to ask you questions about that.
Okay.
I want you to look at the headings at the top of the chart. And I'm talking specifically about right here. Okay?
Okay.
The first asterisk notation at the top is that the alleged event is approximately 12 p.m. on February 6th of 2019. I want to clarify that. Because there's no information reported as to an exact time that Mr. Cochran was allegedly injected with exogenous Lispro insulin, you chose 12 noon on February 6th, 2019, correct?
Yes, based on my review of the investigative information and the medical records, it appeared that that was basically, again, it's approximate. So
Okay.
I'm not saying it's noon, but it's around then that they were saying the event or his
So
problem started.
It's kind of a guess from you, from all these records, because we don't have any exact time, correct?
Correct. There's no exact time, but if I made that assumption, and that's why I asterisked it, that to make a meaningful calculation, I just chose, when they say noon, I chose the number evenly, 12:00, as a time to calculate, as a starting time point.
And that information is essentially gathered from when it's alleged Michael Cochran passed out, and when he got to the hospital and a series of events after that. Is that correct?
Correct.
Okay. The second heading, right here, and you can't see it very well, but it says, hypoglycemia is sugar less than 70 milligrams per deciliter in a person without diabetes. Correct?
Correct. That was the medical definition of hypoglycemia, as I understand it.
Okay. And you remember Dr. Krieger's testimony. She kind of went back and forth. She estimated, but she said at your first timeline, February 6th of 2019, and you've got 2020, which is 8:20 p.m., right?
Correct, on the 6th.
She said, in reference to these questions, that a reading of 21 blood glucose was certainly hypoglycemia or indicated hypoglycemia, right?
I don't recall exactly, but I would agree with that statement.
Okay. But you chose 70 milligrams, and you say that's based on your research and the literature you reviewed. Is that correct?
Sure. So hypoglycemia is a range, or a critical level, if you will, a critical blood sugar. And my understanding and research is that anything below 70 is abnormal, and the lower you get, the more abnormal it is.
The first column is date and time, right?
Yes.
The second column is the reported blood glucose levels in Michael Cochran's body, or allegedly, right?
Yes.
Third column is the hours since the alleged event, and you're picking 12 noon as the alleged event when you believe he may or may not have been introduced with exogenous insulin.
So, right. So let me just clarify. The blood glucose wasn't an allegation. These are laboratory values I've extracted from the medical record. So they're the exact numbers. And again, I had to define a starting point as an assumption, and then those hours are how long after we're looking at those, at that time stamp, if you will, the resultant blood glucose.
Dr. Halsey today testified that he thought the activity of Lispro insulin, or how long it's working in the body, was 4 to 6 hours. Did your research in the literature indicate the same thing?
Yes, so my main source was the manufacturer's insert that has all the sort of description, dosing, and what's called pharmacodynamics, how it works in the body. So it goes through what the activity of this is, because I'm not diabetic.
Okay.
So I had to educate myself.
And I just want to clarify that statement.
Right. that
You're
is-
talking about if Lilly Pharmaceutical is the manufacturer of this type of insulin.
Yep.
They put a information sheet or sheets in with the Humalog insulin, and they have all of this data in that information, correct?
Correct. I'm familiar with insulin, but I had to refresh my mind with the details of this short-acting insulin. And so what Dr. Halsey said was supported with that literature. It's 4 to 6 hours of, the longest it'll act in the body is 4 to 6 hours.
Okay, and another point of information I have to make clear to the jury. Is it your estimation that once Humalog Lispro insulin is introduced into the body, although it's fast-acting, it still takes time to work, approximately 15 minutes. Is that correct?
Correct. So this is deemed a fast-acting insulin that starts to work about 10 to 15 minutes after injection.
Okay. The first reading has a blood glucose level of 21. Where did that information come from, if you recall?
Yep, it's within the first pages of his medical records when he presented.
Okay. Now, the significance of that is the hours after insulin was allegedly introduced to Mr. Cochran's body. This is 8 hours and 20 minutes afterwards, right?
Yes, approximately.
Can Humalog Lispro insulin possibly be working in the body 8 hours and 20 minutes later?
I can only,
From your research
Right.
and your literature.
exactly, the way I was, that it's been described and I read about, the maximum window of action is up to 6 hours. So we're beyond that time in this chart.
And you have listed in the last column, was Lispro active in his body? You state no at that first entry, correct?
Correct.
Okay. I'm not going to go through all of these listings because the jury's seen it before.
Okay.
Would you describe for me the important blood glucose readings which you have marked in bold?
Sure, it's just for ease of reading and pointing out the events which were hypoglycemia as defined by blood sugar less than 70. There were a total of 4 events during his hospitalization, the first occurring at presentation, and then subsequently on February 7th. There were 3 events throughout the day, or throughout the morning, from a little after midnight all the way through 10:30 in the morning. There were 3 other episodes of hypoglycemia.
Okay. I'm pointing to the first one, correct?
Correct. That's his presentation. Yes.
I'm pointing to the next one, which is right here.
Yes, the second bolded number.
Okay. The third one is right here,
Correct.
and the last bold one is right here.
Yes, the bold doesn't necessarily come through as clearly on the
Yeah,
projection.
that's why I'm trying to point them out.
Got it, okay.
Now, according to your chart, your research, all the information that you've gathered, if Michael Cochran was allegedly injected with Lispro Humalog insulin, and its activity is 4 to 6 hours, can you affirmatively state that these listings definitively show Michael Cochran could not have been injected with Humalog Lispro insulin to cause these blood glucose readings?
Correct, that this far out, starting 8+ hours out, and based on the nature of Lispro, these are not resulting from that administration.
There was testimony that the volume or amount of Humalog Lispro insulin introduced in the body changed the duration of activity. Is that what you discovered?
Well, I think that's a complicated question. You can't really inject anybody safely with a volume to test it. What Lilly has said, they don't specify dosages, okay? They just say that upon administration to the body, this is the peak time, it starts working at 10 to 15 minutes, it peaks at 1 hour, and then when it fades off, it still has activity up to 6 hours. That's all I can use as a reference.
Okay. Now, if Michael Cochran were injected with another dose at a later time from 12 noon on February 6th,
Okay.
that would actually confirm your listings. In other words, it would put the timeline farther out, and the blood glucose levels could not be affected by a second injection later on. It would, because your first reading is 8 hours and 20 minutes after injection. If someone injects later, it pushes everything back, right?
Correct. This chart is based solely on the assumptions of a single administration around noon. Okay, I was not aware or did not calculate anything based on any other times.
And I think you may have answered this, but I'm going to ask again. Does the volume of insulin introduced affect the duration of the activity in the body? Is its duration still 4 to 6 hours, if you don't?
I don't know.
Okay.
Can I just clarify that answer?
Sure,
Yeah,
go
I
ahead.
mean, I'm basing my information completely based on the manufacturers and published literature. Everywhere that I've read about Lispro, Lispro insulin, that's the time range that's given. It's never differed. It's really reliable. We have a lot of diabetic patients that use it, and it's given basically around meal times too. When you eat, you've got to have a response that diabetics don't have. And so it's well timed out to help them respond to the carb load, the glucose load from meals. So everywhere I've read, it's 10 to 15 minutes after injection, peaks at 1 hour, lasts anywhere from 4 to 6 hours. And I was not provided anything in the literature or the insert to say otherwise.
So the literature and your research, et cetera, doesn't address the volume question and the duration of activity. Is that right? There's no literature or information about that, as far as you know.
I mean, volume is dependent on the dose you need, the units, which is calculated based on a carbohydrate load. And this is going beyond my expertise because I'm not an endocrinologist.
Okay.
But
okay.
I don't know anything further about Lispro than what I stated.
Fair enough. In a kind of summary and conclusion, all of this discussion that you presented here today in your report, does it indicate, as Dr. Kubitschek stated, that the manner and cause of death are undetermined, and his conclusions and findings say that? He doesn't specifically say any actual manner and cause of death. He says they're undetermined. Do you agree with that finding?
Sure.
Based on all of this testimony in your report?
Yes, my report has detailed my thoughts, and as I've spoken to you today, various factors, regardless of what we think might or might not have happened, the body was decomposed, and both examinations, postmortem examinations, did not help narrow all the possibilities. And so given that, a cause of death is undetermined in my opinion, as well as the manner of death. So causes, why did he die? I cannot tell. And once I can't tell that, although there are various reports of circumstances around his death, I cannot be sure to pigeonhole it further, and so it needs to stay undetermined. So that's how I would certify this death.
Would you agree that any other finding, including Dr. Uribe's conclusion of homicide due to exogenous insulin administration, is unsupported and unsubstantiated by all of your research and testimony?
Yes.
are your opinions in your report and what you've testified to here today to a reasonable degree of medical probability?
Yes.
And your conclusions, testimony, report, they are in your work as a medico-legal expert and consistent with the standards of your profession.
Yes.
And I believe I've already moved for the admission of Dr. Banerjee's report. If not, I'll do so now.
I think you already have. That's right, Madam Clerk.
Which exhibit is that?
It's 12.
Yeah.
12. It's been entered.
I have the official copy.
Thank you.
Cross-examination?
Okay.
Doctor, you'd agree with me that to make an accurate report and render appropriate opinions, you'd need an accurate history. Isn't that true?
Sure.
Okay. How did you get into this case?